can we go to some more visuals to demonstrate the point that you're making about Facegenics and the FME carefully planning the orientation of the jack screw of the expander?
Yeah, let's look at some things here. So first off, so this is an example of some of the landmarks that are used. You can see here, this is from a workup from one of the FME cases that we're doing. And so you can see they're looking at, they're looking at the cheekbones, they're looking at the symmetry between the lower jaw, the upper jaw, and the nose up here. And they're using these landmarks to help identify where, horizontally and vertically, all three planes of space, we want to dial that in as good as possible. Here's some other examples here. This shows how the TADs are planned. So what we're looking at here is a cross section of the top jaw. You can see the front teeth on the top and the bottom here. So these are fitting, forward. So we're looking back. This is the jaw here. And you can see this is the outline of the anchor bodies. You can see here, actually, if you blow into your question earlier, you can see how those threads lock into the anchor body there.
Oh, wow. That's a great visual of the locking TADs.
Yeah. And then this is the bone. So you want to traverse through the bone and you want to have bicortical engagement. So you want to go through the second cortex here. And so that's what that's showing there.
Why is there an extension of the TADs, that second outline that goes much deeper into the nose?
So that is just a visualization tool. So this is kind of the range of TADs that they can use. So there's never going to be a TAD that's placed that long. But basically the library and the way that they use it, they have different lengths of TADs that they can select. And so this kind of shows basically all the options. So if they were in an area that they needed, a deeper TAD, they could do that.
Got it.
Yeah.
Okay, fantastic.
In this case here, you can see that all three of these TADs are the same depth. And that was all that was needed in order to get bicortical engagement here.
Can you point out the bicortical engagement? That's another concept that people have a hard time visualizing.
Sure. So this wider bone here is cortex, and you can see this wider bone here is cortex. Pretty much all of your bones have cortex on the outside, which is denser bone. All right, so that's like the strong bone. And then in the middle is the cancellous bone, and that is a little bit softer and easier to manipulate and move through. So if you put a TAD in and you don't get bicortical engagement, so let's say you put it in and it only goes to like here, it doesn't go through this second cortex. Well, then what happens is it's very similar to just, there's basically wiggle room there. So the TAD itself can actually start to move within this spongy bone in the middle, and it's not as predictable. So when you engage both this cortex here, this white cortex here, and this cortex here, it creates more of a lock around that TAD so that as you're pushing, there's less tipping, there's less dragging, and it's more predictable. Your anchorage is better.
Wow, so bicortical engagement is not just about depth, it's about really securing the high end of the TAD in locking it in place in that second cortical layer.
That's exactly correct. So the stabilization of the TADs goes way, way up when you're able to do that. Now, some areas you may not be able to do that. For instance, if you're going from here and trying to get, bicortical engagement all the way to here or something like that, it may be too long. And so in that case, you're going to engage as much bone as you can. But typically from about the first premolar back, you're always going to be getting bicortical engagement. Because the bone is thin enough to go through it with the TAD.
Got it. Yeah, could we get to the visual about the, continue explaining the landmarks that are used to plan the appliance?
Sure. Yeah. So this is another example here. You can see this is taken all the way up to the base of the zygoma here. So there's a lot of different angles. This is taken from the skeleton as well. So you can see where the facial midline is compared to
these lines have significance, right?
That's correct.
These axes that we're seeing?
That's correct.
I don't get it, really. I know they're trying to plot something, but what are those lines telling us?
Yeah, well, so basically what they're telling us is where if your head is in, the right spot, looking forward, straight, symmetrical, the way that most people look at you, what are those axes, right? Because the jaw and the teeth sometimes tell a different story, right? So you may be symmetrical here, but then down here you're not. So when you're expanding, if you're considering, well, maybe we can make that a little bit better. So let's say, the top of your jaw is symmetrical, like from here up, it's good, but the bottom half is slanted to the side. It's completely off to the side. Well, when you go to expand, if you could do something that levels that out, meaning change the forces. So instead of just placing it on the jaw the way the jaw is crooked this way, change the force so that the screw is going this way, then you can actually start to move this side up more, this side down more, and start to level the jaw as it's expanding. So that's the direction that they're going. They want to be able to do that predictably.
That's what you meant when you said three-dimensional expansion.
Correct. You want to make sure that in all three dimensions, it's controlled. And right now, it's fairly well controlled, but again, we can't look at every single spot where the maxilla attaches to the rest of the skull and know exactly how much resistance all of those points are going to have.
How does the approach that they take differ from Dr. Lipkin's sort of rule of thumb, which is to make the expander parallel to the bite plane, or rather than to the palate itself, because sometimes they differ, and if you always follow the palate, sometimes you create an asymmetry or a cant that way.
Yeah. Well, I'll back up a little bit. So one of the challenges, or one of the things that is fairly well known in this space, is that if you have an existing cant, it gets better or worse with MARPE. Generally worse, right?
Right.
Well, the reason for that is as you're expanding, your two things are happening. Jaw's coming down and forward. And if there's any asymmetry, the actual forces of the appliance, if it's placed relative to where the palate is and the occlusal plane, if both are slanted, you're just, not only is it going to, even if you expand it perfectly symmetrical, it's going to look worse because it's coming down. But if you get at all asymmetric expansion, the jack screw itself in the middle is pointed down on this side, up on this side. It's going to make it even worse. And so if the jaw is slanted like this, the idea behind FME is like, let's get the screw put in like this, or maybe even like this, and try to correct it as we go. So this is the part where, I haven't seen cases where we've corrected 4 millimeter vertical discrepancies by doing this, but this is the direction that they want to go. And so you have to decide where you're going to place it. A good rule of thumb, just to try to get even expansion, meaning to get the right side to expand as much as the left side, even if it's slanted, is to do exactly like Dr. Lipkin says, like put it in, with the occlusal plane, with the skeletal plane, just kind of make it even, and then you'll get even expansion. So one side's not expanding more than the other. And then you can deal with the slant in other ways. You can put some TADs on the side, move that whole side up, or use rubber bands to bring the other side down.
Right.
So that's kind of the workarounds now. But if we could predict and get the skeletal expansion controlled to exactly how we want it as we're going, and be able to modify that as the expansion is happening, that would be very significant.